Today my lecture will focus on the formative context of community psychology. After I finish my lecture, you will identify the various contexts of the field of community psychology, know how these contexts shape the value system of community psychology, and also you will be able in a position to gain a deeper understanding about the historical background of community psychology. Let's begin with a brief introduction. Community psychology can be seen as a response to the dissatisfaction with the traditional practices and treatment and intervention in psychology. Heralded as a third revolution in mental health, the field of community mental health is proclaimed as radical change in perspective on human malfunctioning and its alleviations. In 1966, the Community Psychology Division of the American Psychological Association was formed, and in 1973, the American Journal of Community Psychology began its publication. The first textbooks were published 4 years later. Community psychology can be seen as a response to needs unmet by traditional psychotherapy and other forms of psychological treatment and intervention. Dissatisfaction was centered on the limited usefulness of psychotherapy, lack of availability of mental health care to the lower social class, and the overcrowding mental hospitals. Many other issues were also involved, such as the increasing recognition of the influence of social systems on behavior, dissatisfaction among clinical psychologists with the medical models of treatment dominating the area of psychology, and the desire to channel resources to the prevention of social problems and to health promotion in addition to treatment. There was a growing realization that there would never be sufficient professional helpers to provide individual treatment for all people who require help, and that resources would need to be reallocated from the treatment, which was tertiary prevention, to primary prevention. In my module, 5 forces I will discuss with you that have influenced the emergence of community psychology. Although many forces have been involved, these 5 emerge as a major one and represent an increasing community-oriented thinking about personal community and social problems. Now these 5 are: number 1, interest in preventive perspectives; number 2, reforms in mental health systems; 3, developments in group dynamics research and action; 4, movements for social change and liberation; and 5, the undercurrent of optimism about social change efforts. Let me talk to you about a shift from treatment to prevention here. Born out of the realization that treatment is not the answer to elimination of a disease, prevention was sought to be incorporated into the mental health scenario in an attempt to curb brewing disorders before they became very severe conditions. The development of a preventive perspective on mental health services was influenced by the concepts of discipline of public health. Public health is concerned with preventing illness more than treating it. Prevention may take a variety of forms: sanitation, vaccination, education, early detection, and treatment. Moreover, public health takes a population perspective, focusing on control or prevention disease within a community or society, not merely for an individual. Thus, aiming for long-term success of interventions after World War II, a few psychiatrists began applying public health perspectives that emphasize environmental factors in mental disorder. They proposed early intervention for psychological problems and community-based services as primary modes of intervention rather than isolation in hospital settings. Furthermore, they wanted to use community strengths to prevent problems in living. Now, this new approach emphasized the importance of life crises and transitions as the points of preventive intervention for mental health services. Rather than waiting for full-blown disorders to develop, the mental health clinics could develop education about the coping and support for the bereaved to have a preventive effect. While prevention initiatives represented important innovations, they encountered sharp resistance by advocates of the traditional clinical care and did not yet enter the mainstream of either psychiatry or clinical psychology. Let's move on to the next topic, which is the emerging changes in the mental health system. A second force leading to the emergence of community psychology involved major changes in the United States system of mental health care. These began with World War II and continued into the 1960s. After the war, the Veterans Administration (VA) was created to care for the large number of veterans with medical, including mental disorders, faced by the veterans traumatized by war. In addition, the National Institute of Mental Health (NIMH) was established to coordinate funding for mental health research and training. Both of these federal administrations relied heavily on psychology. Also emerging in the post-war society was a movement for reform in the quality of mental health care and reducing reliance on large mental health hospitals. Advances in psychotropic medication made prolonged hospitalization less necessary, strengthening reform efforts. Between 1972 and 82, the number of hospitals with more than 1,000 psychiatric beds was reduced by 50 to 80% in Denmark, England, Ireland, Italy, Spain, and Sweden. Similar patterns occurred in North America and Australia. With so many large mental hospitals closing, new models of care were needed. In 1961, the federally sponsored U.S. Joint Commission on Mental Illness and Mental Health recommended sweeping changes in mental health care. In one of the Commission's studies, psychologist George Albee in 1959 reviewed recent researches that documented surprisingly high rates of mental disorders compared with the cost of training clinical professionals, and concluded that the nation could never afford to train enough professionals to provide clinical care for all who needed it. Albee and others called for an emphasis on prevention. Psychologist Murray Jahoda headed efforts to broaden thinking about mental illness by defining qualities of positive mental health. This was a forerunner of current concepts of wellness, resilience, and strengths. Jahoda also advocated identifying conditions that inhibited personal mental health and altering those conditions through prevention and social change. However, in their final report, most Joint Commission members remained committed to individualized professional treatment. As a response to the Joint Commission report, the NIMH proposed a national system of community mental health centers. With the support of President Kennedy, whose sister suffered from a mental disorder, and through timely advocacy by members of Congress, the NIMH and the National Mental Health Association, Congress passed the Community Mental Health Centers Act in 1963. The community mental health centers were given a different mandate than traditional psychiatric hospitals, including care for persons with mental disorders in the community, crisis intervention and emergency services, consultation with community agencies, for example the schools, human services and the police, and the prevention programs. Indeed, in many countries, community mental health centers were founded with the charge of developing care for serious mental health problems within the community context where people lived rather than in remote hospitals. The implementation of the CMHC's approach led directly to discussions that resulted in the emergence of the field of community psychology. Let us talk about the influences of social psychology on community psychology. A third force influencing the development of community psychology originated in social psychology, the group dynamics and action research traditions that began with Kurt Lewin. The first community problem into which the Lewin Action Research Team became involved was not primarily a mental health issue. The team was asked to help develop methods to reduce anti-Semitisms in Connecticut communities, and it began conducting citizen group discussions. The insistence of citizens that they be included when psychologists analyze these discussions and their disagreement with those psychologists' views led Levin's team to focus on group dynamics and to the creation of training group methods, the T groups as they are called. After Levin's death, his students and others founded the National Training Laboratories (NTL) in Bethel, Maine, a center for professionals and citizens to learn about the dynamics within and between groups in everyday life. The NTL workshops focus on the development of skills for working in groups and communities. They are not therapy or support groups and are not clinical in orientation. Instead, they embody the social psychological concern with group dynamics. This approach ran counter to the prevailing individualism and laboratory focus on psychology, and involved a collaborative partnership of professionals and citizens. Several early community psychologists worked with NTL, thus linking the group dynamics and action research tradition with innovations in prevention and community mental health. The Levinian focus on action research in collaboration with citizens was a forerunner of community psychology research that we see today. Let's move on to social movements now. A fourth force influencing the development of community psychology in many countries involves movements for social change and liberation. For US community psychology, the civil rights and feminist movements most directly influence psychology, but the peace, environmental, anti-poverty, and gay rights movements were also important. These movements are associated in the popular mindset with the 1960s, although all had a much longer historical roots. They reached a crescendo during the 1960s and early 1970s, bringing their grievances and ideals to national attention. The ideals of these social movements had several commonalities. One was the challenging of hierarchical, unequal role relationship between the whites and the people of color, men and women, experts and citizens, people of heterosexual and homosexual orientations, and the powerful and the oppressed. Youth often assumed leadership. Another commonality of these social movements was that they sought to link social action at the local and national levels. Advocates in each movement pursued changes in local communities and nationally. The movements advocated changes at each of the ecological levels. The feminist movement has shared many goals with community psychology and continues to challenge the field. In 1968, psychologist Naomi Weinstein gave an address with the spirited title Psychology Constructs the Female, or The Fantasy Life of the Male Psychologist. Weinstein's paper has been described as an earthquake, shaking the foundations of psychology. A formative event for many women in community psychology and women's studies. Let's move on to the fifth force, which is optimism. Optimism has provided underlying support for previous forces that I have talked to you earlier. Optimism and the ability to find solutions for social problems is a major force. Optimism supported the emergence of community psychology. In 1965, the Johnson administration initiated a collection of federally funded Great Society programs, popularly known as the War on Poverty. These included educational initiatives such as the Head Start, job training and employment programs, and local community action organizations. Federal funders of community mental health and of the War on Poverty look to the social sciences, including psychology, as a source of scientific solutions to social problems. Now, this attitude grew out of a faith in science and technology based on experiences of the World War II and the Cold War, and gaining clearest expression in the space program. That faith has since been replaced by a more sober sense of the real but limited utility of social science for social change. Let's move on to settings for development. Community psychology emerged not simply from individuals, but from trailblazing settings. Many of them where psychologists and citizens worked together. The exemplary settings that led to the growth of community psychology were the Wellesley Human Relations Service, the Community Lodge, the Yale Psychoeducational Clinic, and the Primary Mental Health Project. The Wellesley Human Relations Service was founded at the request of community leaders. While other mental health professionals asserted their special knowledge of mental disorders and treatment, Eric Linderman, the service's first leader, stressed the importance of learning from citizens and enabling them to take responsibility for the mental health of their community. Donald Klein in 1995 described preparing for a meeting with community leaders in which he planned primarily to inform them of what the service would do for their community. Even in interviews conducted decades later, key interpersonal qualities came through when Don Klein and Jim Kelly discussed their years with the Human Relations Service. Certain gentleness, an appreciation of community strengths and of listening carefully, and attention to personal relationships. These were the important things that came out of it. These are rooted in part in the Linderman's leadership style. Klein's experiences with the National Training Laboratories based on Levin's group dynamics work, and the experience of working alongside citizens as partners in Wellesley. The community lodge went further, creating a setting that empowered men with psychological disorders. George Fairweather and colleagues at a VA hospital began by seeking to improve group therapy with their patients. Their experiences and research eventually led them to finding that a group of men with serious psychological disorders working together and helping each other in their daily lives could live together successfully outside the hospital. The success of the community lodge contradicted many professionals' assumptions about the capabilities of persons with mental disorders. Its success was principally due to the emergence of unrecognized strengths and mutual support among the participants. Seymour Saracen described the Yale Psychoeducational Clinic as having three aims: One, to understand the culture of the school and how that often inhibits productive learning. Number two, to gain that understanding experientially through performing services in schools. And finally, to model for university students the everyday practical involvement of their faculty in schools. Now, these goals indicate a willingness to step outside the usual research methods, to ask open-ended questions, and to learn from rigorous analysis of personal experience and to take risks to promote learning. Emery Cowan has been described by George Albee as the tallest oak in the forest of prevention. Much of his stature came from the Primary Mental Health Project, PMHP as it is popularly known, and the Center for Community Study that Cowan founded and headed at the University of Rochester. Cowan and colleagues have described how PMHP grew from several mental health revelations in the 1950s. Now, these revelations are: we lack enough personnel to help all children in need. Secondly, early identification of young children with academic, behavioral or emotional problems and prompt interventions would forestall later more intractable problems. And thirdly, the paraprofessionals building positive relationships with at-risk children and helping them learn key coping skills could accomplish at least as much as professional services. In 1963, Cowan and his team developed the role of child associates, who were paraprofessionals working under professional supervision in schools, providing support and tangible assistance to children. Cowan and his team of colleagues and students built PMHP from a pilot project in a single school to over 2,000 schools worldwide. The Center for Community Study broadened its focus over the years to include action research on such topics as social problem solving skills training in schools, preventive services for children of divorce, and child resilience. Its work in prevention and Cowan's concept of wellness helped shape community, developmental, clinical and school psychology. Many influential community psychologists worked with Cowan on PMHP or other projects. An edited volume honored these conceptual contributions and innovative community work. Let me summarize my lecture. Community psychology has grown out of many contexts, 5 of the major ones being preventive perspectives, reforms in mental health system, group dynamics and action research, which has been borrowed from social psychology, social movements and undercurrents of optimism. The realization of limitation of treatment and hospitalization led to the need for nipping the disease in the bud by using preventive practices set in the community settings. The need to improve the quality of mental health care, along with the understanding of the limitations of hospitals and mental health professionals, marked the reforms in the mental health system in the United States. Mari Jahoda's research emphasized on the need for positive mental health. With the efforts of Kurt Lewin, a new thinking emerged where social action and research could be integrated in ways that strengthen both. Social reform and movements that led to this reform had a great impact on the society, and thus the concept of community mental health. Utility of social science for social change, and we also see that many other exemplary settings have also assisted in the development of community psychology.